I'm Dr.sajjad, General Surgeon, lecturer of Nangarhar Medical Faculty and student of PhD CDM, Faculty of Tropical Medicine, Mahidol University. My advisor is Dirajan Assistant Professor Prakikeva Charawatana. I have a case presentation from Afghanistan. My presentation have two parts. In first part, case presentation. In the second part, complete presentation of this disease. In case presentation, I will describe history of patient, physical examination, investigation, and treatment of this patient. In the short history of this case, a 30-year-old female came to DMC Dawudjee Medical Complex from Kunal province of Afghanistan at 13 September 2021, presented with chronic cough for 1 year. She had chest pain. Chest pain was mild and continuous, and also she had history of fever, sometime off and on. She had hemoptysis, shortness of breath at the time of exercise, and also she was from non-educational in poor farmer family, and she lived in urban area. Usually she eats vegetables and sometimes meats. She was non-smoker and non-alcoholism. There was history of keeping animals, especially dog, at home. And there was no history of private hospitalization, and no history of any pulmonary disease and heart disease in her family. Any other question in history? In physical examination of this patient, in general appearance, the patient was conscious, no pale, no cyanosis and clubbing, no nasal flaring. Vital signs were BP 110 and 70, heart rate and pulse rate were 88, respiratory was 26, and temperature was 37.9 centigrade. In chest inspection, chest shape was bilaterally symmetric with normal movement. In palpation of the chest, there was no tenderness, no animus palpable, normal trachea position, in normal chest expansion. In percussion, we found dullness in right lower part of the chest. And also in auscultation, we could not hear lung sound, and the lung sound was absent in the right lower lobe of the right lungs. What will be our clinical impression in DDX? Our clinical impression in DDX are right lower lobe pneumonia, right pleural effusion, right lung cystic lesion, and right lung tumor. For the diagnosing and differential diagnosis, we advise first of all chest X-ray, chest radiography. In chest radiography, we found a round shape with regular border consolidation in lower part of the right lung, maybe a cystic lesion. So for this cystic lesion, we advise some lab investigation. In lab investigation in CBC, we found leukocytosis. WBC was 15,700, and also we advise ELISA, enzyme link immunosorbent assay for the cystic echinococcus. It was positive for the cystic echinococcus. Then we advise chest CT scan for the detecting complication and for the selection of treatment option. Uh, this is the axial plan lungs window chest CT scan. We can see a round shape cystic lesion in the lower part of the right lungs, and also in mediastinal window of the chest with axial plan, we can see a round shape with regular border water density cystic lesion. This is a cystic lesion about 10 centimeter. So the cystic lesion was more than 5 centimeter, about 10 centimeter. Cystic lesion was about 10 centimeter and was infected because the patient have fever and leukocytosis. We choose the treatment option for this patient surgery, because for pulmonary hydatitis, for the treatment of pulmonary hydatitis, we have two options: medical treatment and surgical treatment. So we choose surgical treatment, cystectomy and pericystectomy for this patient. Before surgical procedure, we start albendazole 400 mg BD for 1 week for the killing of scoliosis in the cystic lesion, and also for the prevention of anaphylactic reaction at the time of surgery. We advise hydrocortisone 100 mg before 1 day. And before the schedule for operation, the patient we complete lab investigation and medical consultation for general anesthesia. Then I schedule the patient on 28 September 2021 for the operation. For the operation, we choose right posterolateral thoracotomy incision for the opening of thoracic cavity. We can see a cystic lesion in lower part of the right lung. This is a cystic lesion. We aspirate hydrated fluid and inject 20% saline for the killing of scoliosis in the cystic cavity. This is the adventitia layer of the cystic lesion. We resect and pericystectomy done. After the diastasis and hemostasis, we insert chest tube in the pleural cavity. This is the cyst. After chest tube insertion, we repair the incision layer by layer. This is the chest tube. This is the chest bottle. For follow-up, the patient was admitted for 5 days in hospital. After change the dressing and remove chest tube on 5 day of operation, we discharged the patient to whom with oral antibiotic and analgesic for 1 week, and also albendazole for 3 months. After 1 month, patient came to DMC, and we advised LFT in chest X-ray, and also the patient wound was healed after 1 month. After 1 month chest X-ray, just we found small fibrotic changes in lower part of the right lungs. In the second part of my presentation, I will describe shortly pulmonary hydatitis. Introduction in epidemiology, life cycle of hydatitis worm, pathogenesis, clinical feature, diagnosing and imaging, and treatment. Hydatitis disease is a worldwide zoonotic disease caused by the larval stage of Echinococcus tapeworm. In hydatitis, cystic lesions are involved, liver about 75 to 80%. Because when the larva pass to the portal vein and reach to the liver, the more of them larval size is about 32 micron, and the liver capillary size is about 20 micron, because they involve liver more than other organ. In lungs about 15 to 20%, in other organ about 5 to 10%. This disease is endemic in many parts of the world, like we can see in the map. The dark blue area and countries are high endemic for the alveolar echinococcus and cystic echinococcus. In the dark green area and countries, high endemic for the cystic echinococcus. In the light green area is high endemic for the alveolar echinococcus. In the pink country in area, endemic for the cystic echinococcus. In the white area, non-endemic for the alveolar and cystic echinococcus. Also, Tajikistan and Uzbekistan is neighborhood to Afghanistan. The annual incidence rate in this country has been estimated to be as high as 52 to 25 to 27 cases per 1,000 in the 1 year. Life cycle in pathogenesis. Echinococcus has 3 hosts. Definitive host is dog and other canines, and the intermediate hosts are sheep, cattle, goat, and others. And the humans are accidental host when humans are ingest the contaminated food in water with larva or egg of echinococcus. Then they involved liver, lungs, and other organ by hydatitis. The hydatitis has 3 layers: adventitia layer, or pseudocyst, or pericyst. The second layer is laminated membrane, or ectocyst, white elastic sheet. And the third layer is germinal epithelium, or endocyst. How we can diagnose pulmonary hydatitis? We have 3 options for the diagnosis of pulmonary hydatitis: clinical findings, serologic value, and imaging features. In clinical feature, A pulmonary hydatitis, uh, the hydatitis symptom depends on the following factors like involved organ, size of the cyst, and symptom of complication. Sahita et al. Reported asymptomatic cyst, asymptomatic pulmonary hydatitis in 37% of 763 cases, and symptomatic about 63%. Symptom of pulmonary hydatitis: cough about 50%, chest pain about 25%, dyspnea 13%, hemoptysis 11%, fever 8%, hydatitis 5%, anaphylaxis 3%. And some of them have symptom of severe complication like symptom of pleural effusion, empyema, and spontaneous pneumothorax. In lab investigation, we can advise routine lab investigation and specific lab investigation. And routine lab investigation, if we found leukocytosis, may suggest infection of the cyst. And eosinophilia is present in 25% of all persons who are infected with pulmonary hydatitis. In specific lab investigation, we advise serum antibodies with immunoglobulin G enzyme-linked immunosorbent assay has been reported to high sensitivity about 96% and specificity about 98%. About imaging modalities play key roles in the diagnosing complication in management of cystic echinococcus of the lung, include chest radiography, CT scan, and MRI. Like in chest radiography, we can see a round shape consolidation. Sometimes the cyst ruptures to the bronchus. Then we can see air fluid level in the cavity. Like also in CT scan, this is the fluid, this is the air. And also in MRI, this is the round shaped cystic lesion. And also this cystic is evacuated to the bronchus, and we can see air in the cystic cavity. For the treatment of pulmonary hydatitis, we have two options: medical treatment, chemotherapy or pharmacotherapy, and also the second is surgical treatment. We cannot advise puncture, aspiration, injection, and reaspiration because it has much more complication for the treatment of pulmonary hydatitis, like air leakage, pneumothorax, hemothorax, and others. What is indication for the chemotherapy of pulmonary hydatitis? Small cyst in 5 cm, patient with contraindication for surgery, like some patient not fit for surgery with anesthesia, or patient refuse surgery. Multi-organ cyst, like in liver, kidney, heart, lungs, and others. Multiple cyst and recurrent cyst, patient with intraoperative spillage of hydatid fluid. We advise chemotherapy, especially albendazole for the chemotherapy. When we cannot advise pharmacotherapy or chemotherapy, when the cyst will be large, that is at risk for rupture, inactive or calcified cyst, bone marrow depression, and pregnancy, especially the first trimester of pregnancy. In surgery, the indication for surgery include large cysts that are superficial and likely to rupture, infected cysts, and cysts in vital anatomical location, cysts exerting substantial mass effect, on bronchus or on mediastinum in other organs. We have various surgical techniques for the treatment of pulmonary heart disease like inoculation, pericystictomy, cystotomy with capitonage, open aspiration, and lung resection. The goal of surgical intervention include removal of entire cyst with preserving the lung parenchyma as much as possible and without allowing intraoperative spillage. Conclusion of my presentation: cystic echinococcus is a zoonotic parasitic disease with global existence. It can involve any organ. Liver and lungs are the most commonly involved organ. Patients remain asymptomatic for a longer period as the cyst grows slowly. Diagnosis is usually based on radiology supported by serologic testing. Surgery is the treatment of choice for a pulmonary heart disease, but in inoperable case or in case with surgery is contraindicated, medical therapy with benzimidazole compound may be tried. In view of its enormous human impact, prevention should be emphasized, particularly in endemic area. Vaccination has a great potential in containing the transmission of echinococcus in the future. Thanks, Marie, for your attentions.